Welcome to the Keeping It Simple series for EMS. I'm going to start off with a disclaimer and tell you one thing. Anything that can be given IV can also be given IO, and your local protocol is going to supersede the doses noted in the series, okay? So I'm going to mention the doses very briefly just so you can familiarize yourself with them, but keep in mind that local protocol is going to supersede what you see in these slides. Before we begin, let's start talking about a pattern, and this pattern is going to help you understand the side effects and even effects of a lot of pharmacological agents that you will use on a daily basis. There are two categories of drugs. First one is fat-soluble. The second one is water-soluble. So every time you have a drug, you can put it into one of these two categories. You can say it's either fat-soluble or water-soluble. It will be one of those two. So let's talk about the fat-soluble drugs first. Now, I'm going to keep this very basic for you because there's only certain things I want you to know. I will go over them with you, and then I will explain to you why it's significant and how it can help you in your daily practice. So the first thing I want you to know is that fat-soluble drugs are drugs that have long half-lives. They have long half-lives. What do they have?
Long half-lives.
Great. They have long half-lives. These drugs also tend to be small. They tend to be?
Small.
And they tend to be processed by the liver. Processed by the?
Liver.
So three things I want you to know. Long half-life, small liver. Say it.
Long half-life, small liver.
Long half-life, small liver, and these are your fat-soluble drugs. Now, what am I talking about? What am I referring to when I say this? A long half-life is a half-life that is 12 hours or longer. Understand? How many hours or longer?
12.
So that means a drug with a long half-life is going to be given once or twice a day because you have 24 hours in a day, right? So if it's a 12-hour half-life, you'll give it twice. If it's more, maybe you'll give it once. So that means that fat-soluble drugs have long half-lives. They're small, okay? They're small molecules, and they happen to be uncharged in your body. I don't care for you to really know that, but I'm just mentioning it. But I do want you to know that they are small. They are what?
Small.
Now, why does that matter? It matters because of this. You have phospholipid bilayers, and you probably learned that way back when you took bio. If you forgot it, don't worry about it. This is what I want you to know. Membranes, okay, have an outer layer. Let's keep it simple. That outer layer is made of fat. What is it made of?
Fat.
You see that picture right there? There's like an oil guy in orange. He's like talking to two guys that are water and they're in blue. And the guy in blue, the water drop goes, hey, you guys want to hang out? And the oil drop goes, I can't mix with you guys. And the other guy goes, hydrophobe. See that? That's because the oil and water don't mix. Oil is fat soluble. Water is water soluble, right? So when you have this layer outside of membranes, and I told you that layer is made of fat, it's made of?
Fat.
And fat loves fat. What does fat love?
Fat.
Fat loves?
Fat.
And water loves?
Water.
So fat loves fat and water loves water. Understand? So if fat loves fat, that means in order for a drug to get inside a cell or to get through a membrane, and since that membrane is made of fat, that drug must also be fat soluble because fat loves fat. So, since fat loves fat, and you want to get through a membrane that is made of fat, and fat loves fat, so the fat-soluble drug will have an easy time getting through that membrane, right? And it's able to do that because A, it's made of fat, it's fat-soluble, B, because it's uncharged, which you don't have to pay too much attention to, but C, because it's small. If it's fat-soluble, it can get to where it wants to go easily. So if it can get to where it wants to go easily, that also means it can stay there longer. That's why it has a long half-life. It's easy for it to get there, and it loves the environment, so it can stay there. Easy to get there, it can stay there, it has a long half-life. Now, let's review. Will a fat-soluble drug have an easy time crossing membranes that are made of fat?
Yes.
Right, so it'll have an easy or hard time?
Easy.
Easy time. So what I'm going to do now is I'm going to mention membranes, and you're going to tell me if a fat-soluble drug can get through that fat-soluble membrane. First of all, I'm going to keep it simple and just point to stuff in this room and call them membranes. Let's act like that wall is a membrane. Can a fat-soluble drug get through that membrane?
Yes.
Can it get through that membrane?
Yes.
Can it get through that membrane?
Yes.
Can it get through this membrane?
Yes.
Now I'm going to give these membranes names, and you tell me if it can get through it or not. Can it get through your pancreas and cause pancreatitis?
Yes.
Can it get to your CNS and have a high CNS toxicity risk?
Yes.
Can it get to your muscle and cause myositis?
Yes.
Can it get to your eye and cause cataracts?
Yes.
Excellent. So this is why fat-soluble and water-soluble pattern becomes important, because if you know whether it's fat-soluble or water-soluble, you can figure out whether it's going to be hard or easy for it to get somewhere. And if it's fat-soluble, it can get to all those places and have all of those side effects. Okay? So when we talk about drugs, you can put it in that context. What else do you need to know about this? This is the third thing on that list, is that these drugs are processed by the liver. These drugs are processed by the
liver.
So does that make them hepatotoxic or nephrotoxic?
Hepatotoxic.
Makes them hepatotoxic. Excellent. All right? So I want you to put that thought aside, and let's now discuss the opposite, which is water-soluble. So we talked about fat-soluble, and the opposite of that is water-soluble, so now everything is reversed. Okay? So instead of it having a long half-life, it has a short half-life. Instead of it being small, it's large. And instead of it being processed by the liver, it's being processed by the kidney. So repeat after me. Short half-life.
Short half-life.
Large.
Large.
Kidney.
Kidney.
Understand, one more time. Short half-life.
Short half-life.
Large.
Large.
Kidney.
Kidney.
So will a water-soluble drug have a hard or easy time crossing a membrane that is made of fat?
Hard.
It will have a hard time crossing that membrane. Okay? Is it processed by the liver or the kidneys?
Kidney.
Is it hepatotoxic or nephrotoxic?
Nephro.
Excellent. So a lot of these drugs that we use that are nephrotoxic, we can get rid of them or get them out of the patient's body by simply flushing them, right? You can flush it and make them urinate that out. So that's your fat-soluble and water-soluble pattern. I want you to put that aside, and we will refer to it as we talk about these drugs. Let's start talking about individual drugs, but before we do that, we need to understand something. Drugs work on receptors. Drugs work on?
Receptors.
So if you understand the receptors, you'll understand the drugs, and if you understand the receptors and the drugs, you'll know the side effects, the effects, the clinical indications, okay, and even how to administer them. So let's start our discussion by talking about the autonomic nervous system. The autonomic nervous system is divided into two parts, and we're going to refer to the autonomic nervous system as ANS. So if you hear me talking about ANS, I am referring to the autonomic nervous system. ANS is divided into two parts. Two parts. How many parts?
Two.
Parasympathetic and sympathetic. Sympathetic and? Parasympathetic and? Sympathetic and? Excellent. The parasympathetic part will come first in our discussion today. The parasympathetic system, which is part of the autonomic nervous system, is known as the cholinergic system. Another word for parasympathetic is cholinergic. Another word for parasympathetic is?
Cholinergic.
Another word for parasympathetic is?
Cholinergic.
Another word for parasympathetic is cholinergic, and if you look at the word cholinergic, you see four letters nice and big. C-H-O-L. What four letters?
C-H-O-L.
Excellent. Another word for the parasympathetic system is the cholinergic system. Why do they call it the cholinergic system? So let me tell you why. I don't really want you to worry about it, but I do want to mention it so you are aware of it. They call it the cholinergic system because it uses acetylcholine both presynaptically and postsynaptically to carry out the action that receptor is responsible for. That being said, let's talk about these individual receptors. In this parasympathetic, also known as cholinergic system, most of the receptors are muscarinic. Most of the receptors in the parasympathetic cholinergic system are muscarinic receptors. Most of the receptors in the parasympathetic cholinergic system are?
Muscarinic.
They are?
Muscarinic.
They are muscarinic receptors, and the first letter of muscarinic is?
M.
M. So we're going to talk about these individual receptors so you can understand pharmacology and not just memorize it. And when we have that discussion, we'll talk about the M1 receptor, the M2 receptor, the M3 receptor, and every time I say M1 or M2 or M3, that M I am referring to is the M for muscarinic because most of the receptors in the parasympathetic cholinergic system are muscarinic receptors. We also have nicotinic receptors in the parasympathetic nervous system, but these nicotinic receptors are localized to two generalized areas. How many areas? Two. And like I said, I don't want you to really focus on this too much, but I do want to mention it so you know. And this will come up when we talk about certain neuromuscular junction blocking agents, okay? So it will come into play then. Most of the receptors are muscarinic, but you also have nicotinic receptors, and they're located at two generalized areas, and that is your neuromuscular junction, abbreviated NMJ, and your autonomic ganglia, simply put there, ganglia. So NMJ and ganglia. Ganglia and?
NMJ.
Your nicotinic receptors are located at your NMJ and? Ganglia and?
NMJ.
Excellent. Now that we've talked about the parasympathetic system, and we've said another word for parasympathetic is cholinergic, and we've said and repeated that most of the receptors are muscarinic, let's talk about the individual muscarinic receptors. Before we get there, tell me this. What's the most important part of your body?
The brain.
The brain. What's the second most important part of your body?
The heart.
Third most important part of your body?
The kidney.
Kidneys. Excellent. So you know that rap song, Started from the Bottom, Now I'm Here? You guys heard it before? It's a song by Drake, I think. So check it out. When you get sick, your body's like, I got to save my brain, I got to save my heart, I got to save my kidneys. But if I get sick, started from the bottom, now I'm here. Kidneys go first. This is why so many people have to see a nephrologist in the hospital. This is why so many people in the world are on ACE inhibitors, because when you get sick, the first thing to go are your kidneys. But when your kidneys go, you can take medication, you can be on dialysis, and you can still live. Second thing to go is your heart. But when the heart goes, you die. That's why so many patients with chronic conditions die of some kind of heart failure. They may not always call it heart failure. They may call it congestive heart failure. They may call it AFib, VFib. They may call it myocardial infarction. They may call it dilated cardiomyopathy. I don't care. The heart is failing, and that is why they are dying. The exception to that rule is if they have a muscular dystrophy or a muscular-related problem, because then your autonomics are intact, which means your heart can still beat, but your muscles don't work, and you need your muscles to breathe. So when those muscles stop working, you can't breathe, and you die of respiratory depression, okay, and respiratory failure. I did all that to prove a point. What was the most important part of your body?
The brain.
Second most important part of your body?
The heart.
Third most important part of your body?
The kidney.
So where do you think your muscarinic type 1 receptor is located?
The brain.
The brain. So when I say the M1 receptor is located in the brain, the M in M1 stands for what?
Muscarinic.
Muscarinic. The M in M1 stands for?
Muscarinic.
Muscarinic. And is that parasympathetic or sympathetic?
Parasympathetic.
Cholinergic or anticholinergic?
Cholinergic.
Excellent. So we know that the muscarinic type 1 receptor is in the brain and also in the gut, in the enteric nervous system. So CNS and ENS. What's the second most important part of your body?
Heart.
The heart. So where do you think your M2 receptor is located?
Heart.
In the heart. And the M in M2 is referring to what?
Muscarinic.
Muscarinic. So it is your muscarinic type 2 receptor. And is that muscarinic type 2 receptor parasympathetic or sympathetic? Parasympathetic. Is it cholinergic or anticholinergic?
Cholinergic.
Cholinergic. Where do you think your muscarinic type 3 receptor is located?
Kidneys.
Kidneys. Well, 2 out of 3 ain't bad. M1 is in the brain. M2 is in the heart. M3, muscarinic receptor type 3, is everywhere else. Where is it?
Everywhere else.
M1 is in the
Brain.
M1 is in the
Brain.
M2 is in the
Heart.
And M3 is
Everywhere
one
else.
more time. M1 is in the
Brain.
M2 is in the
Heart.
And M3 is
Everywhere else.
everywhere else. Now I'm going to ask you a series of 6 questions, and the answer every single time is going to be M3. And the M in M3 stands for? Parasympathetic or sympathetic?
Parasympathetic.
Cholinergic or anticholinergic?
Cholinergic.
So these are going to be your parasympathetic side effects that you guys refer to as dumbbells, or your cholinergic side effect that you guys refer to as dumbbells. You may not have been explained or taught why, but I want you to know why, because when you know why, you don't make mistakes. And when you don't make mistakes, your patient probably has a better chance of surviving. So 6 questions. Here we go. Which receptor can I agonize or stimulate to cause an increase in exocrine gland secretions?
M3.
M3, and M stands for?
Muscarinic.
Muscarinic, and that's parasympathetic and cholinergic. So if I increase my exocrine gland secretions, am I going to be wet or dry?
Wet.
Wet. This is why cholinergics make you wet, and why you are taught that anticholinergics make you hot and dry. Which receptor can I stimulate to cause an increase in gut motility?
M3.
And if I increase gut motility, am I pooping more or less?
More.
I'm pooping more. Understand? So do I want to give a cholinergic to a patient that has diarrhea or a patient that has constipation?
No.
Constipation. So do you want to give a cholinergic parasympathetic drug to somebody who has constipation or somebody who has diarrhea? Constipation, because in a person that has constipation, you want to increase their gut motility so they can poop and actually have a bowel movement. And you're going to do that via the M3, the muscarinic type 3 receptor, which is parasympathetic and cholinergic. Which receptor can I stimulate to cause meiosis?
M3.
And if I cause meiosis, am I causing pupillary dilation or constriction?
Constriction.
Constriction. The way I remember that is mydriasis with the D mydriasis has a D, and dilation has a D. So mydriasis with the D causes dilation. Meiosis without the D causes pupillary constriction. Okay? Which receptor can I stimulate or agonize to cause accommodation?
M3.
M3. And once again, that M stands for muscarinic, and that's parasympathetic and cholinergic. Now, these next two are important. Which receptor can I stimulate or agonize to cause bronchoconstriction?
M3.
And if I cause bronchoconstriction, is it going to be harder or easier for that patient to breathe?
Harder.
It's going to be harder for that patient to breathe. That's why you give asthmatics anticholinergics, because that's the exact opposite of this, and we will talk about that in a second. Which receptor can I agonize or stimulate to increase secretions, to increase gut motility, to cause meiosis, to cause accommodation, to cause bronchoconstriction, but also cause bladder contraction?
M3.
And if I contract your bladder, are you going to be peeing more or less?
More.
You're going to be peeing more, right? So think about it this way. Think about it like a balloon, and you take that balloon and you fill it with water, and then you squeeze that balloon. That water is going to come out, right? Same thing with your bladder. You take that bladder, you fill it with urine, and then you contract it or squeeze it. That urine is going to come out. Okay? So everybody repeat after me and say, M3.
M3.
Makes you.
Makes you.
P.
P.
Got it? M3.
M3.
Makes me.
Makes me.
P.
P.
Repeat after me. M3 makes me pee.
M3 makes me pee.
Excellent. M3 makes me pee. So look at all the stuff this one receptor is doing. This muscarinic receptor, this muscarinic type 3 receptor is making you wet. It's making you poop. It's making you pee. Things are coming out of both ends. You can't breathe. Your pupils are constricted and you've lost accommodation. All due to this one receptor. So we're not going to cover cholinergic drugs, but if you see the letter CHOL in some drugs, you'll know that it's a cholinergic drug. I'm not going to mention it because you don't really use them. What I am going to mention are anticholinesterases. Now, before I talk about anticholinesterases, I want to talk about cholinesterase. Okay? Anytime you see ACE in a word, that means whatever's before it is being broken down. It's kind of like axe. Like this is ASC, think about it AXE, okay, like an axe. Whatever's in front of it is being broken down. So cholinesterase breaks down acetylcholine. Understand? It breaks down acetylcholine. That means if you have an anticholinesterase, you are blocking the enzyme that breaks down acetylcholine. So you cannot break down acetylcholine, which means your acetylcholine will not be broken down, which means that you will have more acetylcholine in your body because you have increased the amount of acetylcholine already in your body by preventing it from being broken down. So you're increasing what we call endogenous acetylcholine. It is helpful to know here that antidotes do exist for neuromuscular blocking drugs, and we'll talk about those drugs here in a second. So let's talk about these two anticholinesterases. The first thing I want you to see is there are 4 letters nice and big in both of these drugs, and it is S-T-I-G. What 4 letters?
S-T-I-G.
One more time.
S-T-I-G.
Excellent. Those drugs are neostigmine and physostigmine. Physostigmine and?
Neostigmine.
Neostigmine and? Physostigmine and?
Neostigmine.
Excellent. Neostigmine and physostigmine. Once again, the 4 letters commonly found in anticholinesterases is S-T-I-G. It is what?
S-T-I-G.
Excellent. Let's talk about neostigmine first. Neostigmine can be used to reverse a neuromuscular junction blockade. And remember when we talked about these receptors, we said most of the receptors in the parasympathetic nervous system are muscarinic receptors, but nicotinic receptors are located at 2 generalized areas. This is one of those areas, your NMJ. Okay? So I just want to mention that because we talked about it earlier. Now, neostigmine can be used to reverse a neuromuscular junction blockade. What drug can we use to reverse a neuromuscular junction blockade?
Neostigmine.
Excellent. It's another drug, physostigmine, but I want you to call it fixostigmine. So repeat after me. Physostigmine, fixostigmine.
Physostigmine, fixostigmine.
One more time.
Physostigmine, fixostigmine.
And the reason why we call it fixostigmine is because it's the treatment for an atropine overdose. Now, I'm going to talk about a pattern really quickly, and it's going to come up again in a second. Repeat after me. Overdose.
Overdose.
Opposite.
Opposite.
Withdrawal.
Withdrawal.
Same.
Same.
Overdose, opposite, withdrawal, same. Go.
Overdose, opposite, withdrawal, same.
One more time.
Overdose, opposite, withdrawal, same.
Excellent. Atropine is a anticholinergic. Now, don't confuse anticholinergic with anticholinesterase, okay? Anticholinesterase prevents the breakdown of acetylcholine and makes you more cholinergic. So anticholinesterases make you more cholinergic, whereas anticholinergics make you less cholinergic and more anticholinergic, the opposite of cholinergic. So the opposite of cholinergic is anticholinergic. The opposite of cholinergic is?
Anticholinergic.
And the opposite of anticholinergic is?
Cholinergic.
Excellent. So atropine is an anticholinergic drug. So if you overdose on an anticholinergic drug, you want to make them opposite. Overdose, opposite. Say it.
Overdose, opposite.
You told me the opposite of anticholinergic is cholinergic, and you told me that anticholinesterases make you more cholinergic, and that's why when somebody has an atropine overdose, you can fix that atropine overdose with fixostigmine or physostigmine. What drug can we give to fix an atropine overdose? It's fixostigmine, physostigmine. Say it.
Physostigmine, fixostigmine.
Excellent. So, we talked about anticholinesterases, right? And we talked about how anticholinesterases make you more cholinergic. What do anticholinesterases do?
Make you more
They
cholinergic.
make you more
Cholinergic.
They make you more cholinergic. And remember we said another word for parasympathetic was?
Cholinergic.
Another word for parasympathetic was?
Cholinergic.
So if they're making you more cholinergic, they're making you more parasympathetic. Same thing. And we talked about the parasympathetic nervous system. We talked about receptors. We talked about M receptors, M1, M2, M3. And which receptor did I tell you can increase secretions, increase gut motility, cause meiosis, cause accommodation, cause bronchoconstriction, and bladder contraction?
M3.
And M stands for?
Muscarinic.
Muscarinic. Is that parasympathetic or sympathetic?
Parasympathetic.
Cholinergic, anticholinergic?
Cholinergic.
Excellent. It's cholinergic. So when you have somebody that has anticholinesterase poisoning, that means they are too cholinergic or too parasympathetic, and your side effects and symptoms will be what you guys have learned as dumbbells. And we learned it by looking at the M3 receptor. So now let's look at it with your mnemonic of dumbbells. D for diarrhea, U for urination, M for meiosis, B for bronchoconstriction. What receptor is responsible for all four of those things?
M3.
M3. The other B is for bradycardia. And what receptor is responsible for that?
M2.
M2, because M1 is in the brain, M2 is in the heart, and M3 is? Everywhere else. E, excitation of skeletal muscle and CNS. Lacrimation, sweating, and salivating. Dumbbells. D for diarrhea, U for urination, M for meiosis, B for bronchoconstriction, B for bradycardia, E for excitation of skeletal muscle and CNS, L for lacrimation, S for sweating, S for salivating. How to remember this? Fluids are coming out. Fluids are coming out. Look, diarrhea, urination, coming out, coming out. Lacrimation, sweating, salivating, coming out, coming out. You're wet, you're leaky. Okay? And it's usually due to these muscarinic receptors we talked about earlier. You guys probably learned this mnemonic in relation to organophosphate poisoning. Same thing here, okay? That's what you're going to see. Dumbbells related to these receptors we talked about at the very beginning of this lecture. So cholinesterase inhibitor is another term for anticholinesterase. So if you have anticholinesterase poisoning, we default back to our pattern, which is overdose opposite. So they are too cholinergic. Now we must make them anticholinergic. Anticholinesterases make you more
Cholinergic.
They make you more
Cholinergic.
And the opposite of cholinergic is?
Anticholinergic.
So they're too cholinergic, and you need to make them anticholinergic. And the anticholinergic you're going to use is atropine. Say it.
Atropine.
You know how I remember this? Is if I want to be anti-cold, I go to the tropics because it's nice and warm. If I want to be anti-cold, I go to the tropics. If I want to be anti-cold, I go to the
Tropics.
Where do I go?
Tropics.
If I want to be anti-cold or anti-cholinergic, I go to the tropics. Spell tropics one letter at a time. Go.
T-R-O-P.
Stop. Do it one more time.
T-R-O-P.
Stop. Do it one more time.
T-R-O-P.
Excellent. If you want to be anti-cold or anti-cholinergic, you go to the tropics. So a lot of anticholinergics have those 4 letters, T-R-O-P. So look here, atropine has those 4 letters. It's an anticholinergic. When somebody gets poisoned and has anticholinesterase poisoning, they are too cholinergic. You want to accomplish the opposite. You want to make them anticholinergic. You will give them an anticholinergic, and that anticholinergic is atropine. Which anticholinergic is given for organophosphate or anticholinesterase poisoning?
Atropine.
Atropine, and it's given with pralidoxine, which is known as 2-PAM. It's given with pralidoxine. It's given with?
Pralidoxine.
It's given with?
Pralidoxine.
It's given with?
Pralidoxine.
And it's given with pralidoxine or 2-PAM because eventually you're going to need acetylcholine, okay? And this is going to help you regenerate that. So we use this drug for organophosphate poisoning, and it's given with atropine, which is an anticholinergic. Dosing, like I said, I'm going to mention dosing. I don't need you to know it all. I'm not going to have you memorize it, but I am going to mention it so you are familiar with it. But remember that your local protocol is going to supersede what you see in these slides. Dosing here is going to be 1 to 2 grams and 250 to 500 milliliters of normal saline infusion over 15 to 30 minutes, or 1 to 2 milligrams IM or SQ or sub-Q if IV is not feasible, okay? The way you guys probably learned this drug, or the mnemonic you guys probably used, was that this drug prevents aging of the poison, okay? Prevents aging of the poison. This brings us to the end of this lecture video. Thank you for watching.